So I think we'll get started now. There might be some more people joining in the next few minutes, but that's absolutely fine. So my name's Abby, and I'm currently a F1 working at St Mary's in London. And I'm here today to teach about cranial nerve examination, and we're thinking about it from an OSCE perspective. So this is part 1 of 2 lectures, and today we'll focus on cranial nerves 1 to 6. And then there'll be another session next week that looks at the others. So just to say, this is a lecture that's run by Bite Medicine, which is an online medical education platform. It has an editable textbook, it has lots of OSCE content, which this will be added to. It has 2 question banks, which contribute over 3,000 questions. And also you'll be able to find all of these recorded webinars on their website, as well as having these live ones. So that's a bit about me and a bit about Bite Medicine, and then we'll get started. So as I said, today we're going to be covering cranial nerves 1 to 6. And for each nerve, I'll speak firstly about what it does, and then we'll speak about how you can examine that, and some of my top tips for examining them efficiently in an OSCE. And then for each cranial nerve, we'll talk about some high yield pathology, so things that commonly come up in exam scenarios that you can think about while you're doing your examination. I think this will last about 60 minutes. There is the Q&A function if anyone would like to comment any questions, but I won't be checking it regularly. We'll probably just address them at the end if that's okay. So I thought I'd start with my tips and tricks. These are more specific for a cranial nerve examination, but they can also be applied to other stations. So the first one for cranial nerves is learn a routine, but don't forget function. So there's a lot of different components of the cranial nerve examination, and practicing it regularly with your peers can really help you when you're quite stressed. So you've got something to fall back on. But it's really important when you're doing those examinations, particularly in your exam setting, you're thinking about what you're testing at a specific time. So which nerve am I testing and which nerve is the pathology in? So that you're not just running through a routine, you get to the end and you can't remember which of your positive findings are associated with which nerve. Make use of your reading time. So when I first started doing my OSCEs in 3rd year, I would write out my full examination in the couple of minutes that I had before an OSCE station. I don't think that was the best use of my time, although it did help when I got to the end of a station and I could flick through it and find anything I missed. By finals, what I was doing was, when I was preparing for my OSCEs, I would, every time I practiced an examination, write down the things that I forgot. So I was generating a list of my commonly missed components. And in that reading time, I would then write those things that I commonly missed. So instead of writing all the things that I would always do, I'd write the things that I would commonly forget, so I could come back to them at the end if I'd missed them. And then I would start thinking about the different differentials, and we'll speak about them in a little bit in a minute, and try to anticipate those next questions. So you're really commonly going to be asked what your next investigations would be, so you can start to think about what your answers would be for them. So in terms of differentials, for your actual examination, if your patient has findings, they're not going to be acutely unwell, because they can't have acutely unwell patients in an OSCE setting. So you're thinking about chronic pathology. So when you're in your reading time thinking about what differentials might come up, have a think about what chronic conditions might a patient still have signs for that I might be able to see. But for your further investigation section and your sort of Viva style questions, you might be presented with some more acute findings, so some images of some pathology, like fundoscopy images. So just bear that in mind, that you can't throw all of your acute knowledge out the window. So this one's quite tricky, and I think it's a skill that you learn over time, but try to synthesize your findings in real time. So if you have an abnormal finding, try to think which nerve is abnormal, which side is the nerve on, or is it on both? And is it isolated? Is it an isolated cranial nerve palsy, or is it in conjunction with other abnormalities? When you're doing that, you can then formulate your differentials a little bit quicker when you're then asked them later, and time is often of the essence because you've got quite a few questions to get through. So I think to come up with some differentials, a good way to come up with a lot of differentials is your surgical sieve. So there's a really good mnemonic called vitamin C, D, E, and each letter of that stands for a different type of pathology. So things like vascular pathologies, infective pathologies. And then for each of them, you're thinking about what different differentials could come under them. So for cranial nerves, a vascular lesion might be a stroke, or it might be an aneurysm of your carotid or of one of the arteries in your brain. You might have like a nerve pathology, so a specific cranial nerve. It might be because of diabetes, and you also might have sort of autoimmune things like MS. But I think for presenting, which we'll come on to when we talk about conclusions, the best things to do is think about the most likely things. So what is the most common cause of this pathology? And what are the things that you want to rule out? So what are the really serious pathologies and presentations that you need to think about investigations for to make sure that that patient doesn't have it? Depends on your style and what your med school likes. I think sometimes some really brief sentences on your clinical reasoning can be useful. And I think particularly for differentials that you think are less likely, they can almost validate to yourself why you're saying them, and they can also show to your examiner that you don't think they're as likely as others. So I think this is the most likely thing. These are some other options, but I think they're less likely because X, Y, and Z. And then your further investigations, I've listed some commonly used ones for cranial nerve exams, so things that you can use for any presentation, but then really trying to think about your most likely and your rule out differentials and what investigations you would need to do for either diagnosis of those or for ruling out them. So we'll move on to the examination itself. So those are hopefully some of the things that you've thought about before you've gone into the station. So wipe with an extra I and a couple of Ps is your common mnemonic for how you would start an exam. So wash your hands and any PPE. So I did some of my OSCEs in COVID. So that was gloves, mask and gown, but it might just be gloves. The hand gel might not be obvious in the station, so make sure you ask for your examiner for it if you can't see it. Introduce yourself. So hello, my name's Abby and I'm a X-year medical student. Identify the patient, so name, date of birth, and if you're like me and you can't work out how old they are from that quickly, age. For consenting a patient, I think it's really useful for each examination to have a bit of a layperson, short, sweet spiel that explains what the examination is and briefly what you'll be doing. So this one is taken from the biomedicine website. So I've been asked by the examiner to examine the nerves that supply your head and neck. This will involve me having a look at your face, testing the sensation and asking you to perform some movements. Would that be okay? So that can be understood by anyone. It doesn't go into detail about all the things you'll be doing, but it does briefly sort of prepare the patient for what will come next. Is the patient in any pain? You could offer them some analgesia, and particularly in other types of examination, you can start away from the pain. But in a cranial nerve exam, if they've got pain on the left side of their face, you can start with the right. Positioning for a cranial nerve exam, the easiest thing, because we'll come on to why it makes visual fields a lot easier, but it's the patient sat in a chair. And if you've got a chair that you can sit opposite them, so you're on their level, I think that's a lot nicer as well. And then exposure, so cranial nerves, you mostly need to be able to see just their face, but it's also useful to be able to see their neck and their shoulders, but you can always offer to expose these later in an exam. I think the safe way is to always say what you would ideally expose and ask the examiner if you would like to do that, and the examiner can always say no. So cranial nerves, I think often people forget that you have to start with general inspection. I think when you're thinking about 1, 2, 3, it's easy to jump straight into 1. But remember, you're starting with a global inspection of the patient around the bedside and then looking at the patient themselves. So I put some images of some commonly looked at things that you might notice in a cranial nerve exam. So any IV medications, that might be steroids, it might be IVIG, it might be fluids. Are there any signs up that the patients know by mouth, or are there any alternatives to feeding, like NG tubes or TPN? You can have a look at the patient's shoes. Do they have any special orthotics to help with their walking, or have they got any sort of abnormal tread wearing? So is it more worn on the lateral side of the foot, which could indicate an abnormal gait? Does the patient have a catheter? They might have a problem with the nerves that supply their bladder. Do they have any oxygen? And as always with oxygen, what delivery device is it? And what's the flow rate? So make sure you have a look at the wall. Some patients might have a spirometer at their bedside to make sure that whatever problem they've got is not impacting on their breathing. And you might notice also walking frames, sort of walking sticks as well. The other thing with food you might notice is fluid thickener if they've got an unsafe swallow. So then moving on to the patient themselves. So in terms of their general appearance, what is their body habitus? Are they overweight? Are they have they got any obvious asymmetry? And that could either be in their posture or it could be in their muscle bulk, so comparing left to right. Do they have any obvious weakness or paralysis, which you might notice when they perhaps walk from the chair to the bed, or when they walk into the room, or it might just be from whatever walking aids they've got around the bedside. Are there any obvious fasciculations that you can see, which are muscle twitching, or can you see any scars? And for neuro exams, there's a mnemonic that I think is really commonly taught, which is SWIFT. So S is for scars, W is for wasting, I is for intentional or unintentional movements, F is for fasciculations, and T is for tremor. So then I always think about moving to the part of the body that I am examining. So in cranial nerves, that is the face. So do they have any hypomimia or minimized facial expressions? And that's really commonly associated with Parkinson's disease. Do they have any facial drooping on one side? That could be a stroke, or it could be a cranial nerve palsy. Do they have any ptosis or drooping of the eyelid? Again, commonly associated with a cranial nerve 3 palsy. Ophthalmoplegia is weakness or paralysis of the muscles of eye movement. And you might be able to tell that when you walk in the room. You might notice that the patient has difficulty following you around the room. Is there any pupil size asymmetry, which might be difficult to tell from the end of the bed, but we'll examine it better when we get closer to the patient? And is there any strabismus or obvious sort of misalignment of the eyes or squint? So we'll move on to discuss each nerve in turn. So cranial nerve 1 is your olfactory nerve, which is a sensory nerve, and it's responsible for your sense of smell. So a really quick screen for this is just to ask a patient, have you noticed any change in your sense of smell? More formally, you can see at the bottom with the star, you can offer smell bottles. So these are different sort of scents in bottles that you would offer to the patient to smell with each one nostril at a time. I've never seen this done in an OSCE, but it's quite a nice thing to offer. So some of the differentials that you might be thinking about, I think it's quite unlikely that you'd have an isolated cranial nerve 1 palsy in an exam, but viral infections, again, less likely because they're acute. They couldn't have an infectious patient in an OSCE, but something like COVID is really classic. And then loss of smell might also be a really early sign of Parkinson's disease. So I think you've got 2 choices for how you start your cranial nerve exam, and I'll speak about why I think 2 is better. But so your first one is to ask your patient about all of the sensations at the beginning of the exam. So you can ask them about sense of smell, which is your cranial nerve 1, sight, so optic nerve, taste, which is your facial nerve and your glossopharyngeal nerve and your vagus nerve. And they supply the different thirds of the tongue. So cranial nerve 7 is your anterior 2/3, and then your 9 and 10 are your posterior third. And then your vestibular cochlear nerve is responsible for hearing. I think this can be quite useful if you get worried that you'll forget to ask some of your sensory questions. But I think asking them when you're testing each nerve helps you synthesize your findings better. So I just asked the specific sensation for the cranial nerve that I'm testing. And I think that also, when nerves have a sensory and a motor component, it can help better bring together that in your head. But it's completely up to you. So cranial nerves type 1, quite short, we'll move to cranial nerve 2. So the optic nerve is another sensory nerve that's responsible for your vision. So you first can generally grossly screen, asking if they've noticed any recent changes in their vision. You can also look to see if they're wearing glasses. And I've heard before of students being asked if a patient is long or short-sighted based on their glasses. The trick to do that is to hold their glasses up to the corner of the room and look through them. If the corner of the room looks smaller, beginning with an S, the patient is myopic or short-sighted, S. And if the corner is larger, then they're long-sighted. The other parts of your cranial nerve, which are more specific, so not your gross screening, is your acuity, your fields, your reflexes, and ophthalmoscopy. So those 4 components form a nice mnemonic, which is afro, 3 of which you will definitely be expected to test in an OSCE. Ophthalmoscopy, I think, is less likely, but you should definitely offer it. The other things that you can offer that we'll go through, you can see on the bottom of my slide, a Snellen chart, which you can use a pinhole with as well, Ishihara plates, and then your formal visual fields, which are your Humphrey and your Goldman perimetry. So, as I said, any recent changes to your vision, you can ask if there's any recent glasses changing their prescription or anything like that. I then asked them to cover one eye, doesn't matter which, and I'd ask them, this is a little schematic representation of my Birmingham medical badge. I'd ask them to read the green section of my badge with one eye, and I'd get them to cover the other eye, and I'd uncover the white section, and I'd get them to read the white section. The next thing you're going to offer to do is your Snellen chart. So a Snellen chart looks like this, so a series of progressively smaller letters progressing down the page. You're asking patients to initially try and read the chart from 6 meters away, and you might have heard of 6-6 vision, so the numerator is how far away they are, so 6 meters, or you might have also heard of 20-20 vision, which is the equivalent but in feet. So if you ask the patient to read from the top downwards, you can waste quite a lot of time, especially if their vision is very good and that's not the cranial nerve where the pathology lies. So I think my trick to get through the Snellen chart as quickly as you can in OSCE is to ask the patient to read aloud the smallest line that they can see. If they get that fully correct, ask them to read the line below. If they get 1 or 2 letters wrong, you can see my yellow box on the right. You can have the line that they've read -1 or -2. And the denominator of your 6-6 or 6-9 vision is the smallest line that they can read with no 1 or 2 letters wrong. If they get more than 2 letters wrong, so 3 or more, ask them to read the line above, and you get them to keep repeatedly doing that, so moving up the chart until they get no 1 or 2 letters wrong. If their vision is not 6-6, so if it's worse, the other thing you can ask them to do as well is to use a pinhole. So that's essentially a piece of paper with a small hole in it, and that will correct any refractive error, so things like myopia or hyperopia, because it will help the light converge better on the retina. The thing that I didn't say that's important with the Snellen chart as well is if the patient has glasses on, you should be getting them to do this test with their glasses on. If you ask your patient to read the smallest letter they can read, and they can't even read the top letter, so here the A, the next thing you would ask them to do is move closer, so to 3 meters away from the chart. That would then become your numerator, and you would ask them to again read the smallest line they can see. If they still can't read that big A at the top, you move them to 1 meter. If they still can't read that, your next thing you can do is ask them to count fingers. So how many fingers am I holding up? If they can't count how many fingers you're holding up, you can ask them to see if they can see you waving your hand. And if they can't do that, you can say, can you see the light versus the dark? So you test whether they can perceive light. And if they can't do that at all, then it's no response to light. So hopefully that demystifies the Snellen chart a little bit. The next thing you can ask them to do is you can assess colour vision by giving them some Ishihara plates. So you would, again, with their glasses if they need them, with one eye at a time, ask them to read the letter within the circle. So here it's a 6, to assess whether they can see all the different colours. So I've given some differentials for visual acuity. I think these are commonly more sort of taught in ophthalmology, but it's quite important to sort of be able to integrate your findings into the different systems. So the first sort of, well, most common cause of reduced visual acuity is refractive error. So that's either short-sightedness, where your lens is essentially too strong, and the light rays converge anteriorly to the retina, or it could be long-sightedness, and these are sort of addressed with different shaped lenses. So a short-sighted person needs a concave lens to essentially sort of reduce the strength, so you're converging the light on the retina. Amblyopia is also known as a lazy eye, and it can be either unilateral or bilateral, and it's reduced visual acuity that occurs because there's an insult to the visual pathway that occurs when the visual pathway is developing, and that sort of critical period of development is between birth and 3 months generally. And things that can cause that sort of disruption to the cortical visual development are things like a really high refractive error, like we spoke about, or something like a squint, which is misalignment of the eyes. So retinal disease is sort of a general term, but again, it means that your eyes aren't detecting the light as they normally would, and you're not forming the images or the vision that you normally would. Presbyopia is really common with aging. It's a loss of elasticity of the lens, which causes difficulty focusing on near objects. AMD is age-related macular degeneration, and this causes blurring or loss of the central visual field, and that's commonly due to drusen, which are deposits on the retina, and that can either be wet or dry. Cataracts is where your lens becomes more opaque, so the light isn't coming through the eye, being refracted and converging on the retina as it normally would. And then corneal scarring also affects that same process. So for your visual fields, so we've done acuity, we're moving to the F, visual fields. My top tips are to sit facing the patient, as I said before, so you're at their level, and give them as simple instructions as you can, but we'll speak through them as we go through the different components. So your first part is your peripheral fields, which is really commonly done poorly, and it's because of a really sort of correctable error. So with your visual fields, you're trying to test each quadrant of their vision. So you start using ideally a white hat pin, but if they don't have that in your exam, you can just use your fingers and you can sort of make quotation marks. And you come from the corner of each visual field, and you're testing where the patient can see your white hat pin or your fingers, and you're comparing that to you. So my top tip is, so firstly, ask the patient to cover an eye. This is how you keep it more simple. So don't ask them to cover a specific eye. Ask them to cover an eye and mirror them. So if they cover their left eye, you're going to cover the one that's opposite them. So that'll be your right eye. You're then going to use your white hat pin and come from the corner. I would sit as close to the patient as you can. So I try to sit with my knees not that far from the patient, obviously with them being comfortable. And then I can align the white hat pin with the middle of us, so with my knees, and I know that's roughly the centre. People generally will lean too close to the patient and too far away, or too close to yourself, so too far away from the patient. And that means that you're not directly comparing your visual fields with their visual fields, So you need to try and make it as equidistant as possible. So they're covering one eye. You bring from one corner to the other corner. Preempt that the patient is going to get confused when you move. So ask them to stay exactly as they are, keep that eye covered. I'm going to change my hands. And then you'll use your other hand to cover this eye so that you're at a full reach and you can reach to the far corner of the visual field with your other arm. So you're trying to map out where the patient can't see, and you're trying to picture what their vision looks like in relation to the diagram that we'll go through on the next few slides. The other things that you can test with your visual fields. So using a red hat pin, you can map out a person's blind spot. So it's really, everyone has a blind spot, and it correlates to where the head of the optic nerve comes into the eye. And you use a red hat pin to sort of map out, so you sit again opposite them, about 1 meter away, and you're trying to map out where their blind spot is, again in relation to your own. And the really common differentials for enlarged blind spots are essentially anything that causes a raised intracranial pressure. So stroke or space-occupying lesion, like a mass. But your commonest is actually benign as obesity. Visual inattention, I typically do when I'm in sort of sat close to the patient as well. So using both hands at the same time, you're going to ask the patient to stare straight ahead and stay looking at your nose. You're going to move first one finger and then the other finger, each time asking the patient which is moving. And then the important part of the exam is to move both at the same time and ask which the patient sees as moving. They should see both, that's what a normal person can see. If someone has got something like a stroke, they might only perceive one as moving. And then your sort of more formal visual field testing, which you would offer if there was any sort of gross pathology you picked up on examination, are your Humphrey visual field testing, your Goldman kinetic perimetry, and more formal blind spots you can do off of these. And these might be things that you're familiar with from going to the opticians, where they sort of flash light in different places in the visual field to really map out where someone can and can't see. So I'm going to speak through a little bit of the sort of pathway of how we see, and then we'll talk about some common pathologies that you might be asked about in an OSCE scenario. So everyone has a left and a right visual field, and a visual field is where a person can see when their gaze is at a fixed point. And then each visual field can be divided into a temporal or a lateral part of their visual field, and a nasal or a sort of more medial part of the visual field. And then you've got your retina, and the nasal fibres of your retina are actually responsible for the sort of temporal or the more lateral parts of your visual field. So think about it going in a diagonal line out. And then your temporal fibres, so the more lateral part of your retina, is responsible for the nasal, so the more medial part of your visual field. And just to note, when you're looking forward, the nasal sections of your visual field, so the part that the retina is responsible for, your temporal retina is responsible for, will overlap. So then you've got your retina, you move back down your optic nerve to the optic chiasm, and this is a really critical point in your sort of visual field pathology, because your nasal retinal fibres, so the parts that are responsible for the outer visual fields, decussate or cross at your optic chiasm to join the other part of the optic tract. And then your optic tract, so your right optic tract carries your left-sided nasal fibres and then your right-sided temporal fibres. So your right-sided optic tract is responsible for your left visual field and vice versa for the other side. Your optic tracts cross back to synapse with the lateral geniculate nucleus of the thalamus. And then you've got your optic radiations, which sort of transport the pathway all the way back to the visual cortex, which is in the occipital lobe and sort of more specifically the calcarine sulcus. And we'll talk about why this pathway is really important for interpreting pathology and understanding where a lesion is. So this is a sort of the same schematic representation of your visual pathway, that it's got some pathology marked on and the corresponding visual field defects. And for each, we'll talk about where the lesion is, what you would notice on examination, and some of the common differentials. So a pre-chiasmal defect is any defect that occurs either in the optic nerve or in the retina. And because of that, you will lose vision in the whole of the eye on the ipsilateral side to which the lesion is. And that's because you've got loss of your temporal and your nasal retinal fibres. So you completely lose that half of your vision. So another sort of fancy word for this is monocular, one eye, anopia, can't see. So you can think about your differentials either as retinal or optic nerve, so you can think about them in pathology, but I've just listed some common ones for you. So sort of space-occupying lesion, optic neuritis, and that's really commonly seen in multiple sclerosis. And when you're testing your central fields with your red hat pin, you'll also see that they can't see that red as strongly or at all as you normally would, and that's called red desaturation. Drug-induced, so a really classic one for medical school is ethambutol, which is a TB medication, and the way I always remembered that was associated with visual change was that I begins with an E, and so does ethambutol. Or you could get central retinal artery occlusion or central retinal vein occlusion, which essentially means that you're not supplying your retina with the blood that it needs to be able to work properly, to be able to see. So your optic chiasm defect is your really classic medical school one, and that's because it can be caused by compression from the pituitary. So a really common cause is a pituitary adenoma, where the pituitary gets bigger, compresses on the optic chiasm, and then affects the nerves that cross, which are your nasal fibres, which affect your temporal fields. So you can see from the blue image in the middle that this person can't see anything in their temporal visual fields, which is responsible, the nasal retinal fibres are responsible for. So this is called a bitemporal heteronomous hemianopia, and that essentially means that you can't see half of your vision, and it's a temporal half of your vision in each eye. And other differentials for this are your craniopharyngiomas and suprasellar aneurysms. If you get a lesion of your optic tract, you get sort of the lesion affects the nasal fibres of one eye and the temporal fibres of the other eye, because you'll remember that it crosses at the optic chiasm. So if you get a right optic tract lesion, you can see you've lost the left halves of each field. And that can be caused by an aneurysm that compresses on the tract, a space-occupying lesion, or trauma. If you have damage in your optic radiation, you can get a quadrantopia, and that's because you've got two parts to your optic radiation. So your upper optic radiation goes through the parietal lobe, and I always just had to remember it's opposite. So your upper optic radiation is responsible for your inferior vision field. So if you get a lesion there, you'll lose the inferior quadrant of your visual field. And the superior part of the optic radiation goes through your temporal lobe, and that again is responsible for the opposite, so the lower part of your visual field. So there's a good mnemonic on the bite medicine website, which is PITS, which I think is really useful. So parietal is inferior, and that's your upper optic radiation, and then your temporal lobe, your superior optic radiation goes through. It's a superior defect, sorry, and that's where your lower optic radiation goes through. You can get macular sparing if the lesion is quite far back in the cortex, and that's because there's thought to be some sort of bilateral innervation of the macula, which is the central part of the retina. So that was quite a lot on visual fields, but I think it is one of the most commonly tested pathologies, so it's important to spend time there. So we'll move on to reflexes now. So first inspect, is there symmetry in size and shape, and is the size sort of appropriate for the light that you're expecting? And then you'll move on to your reflexes. So there should be a pen torch in the station. Top tips for this is to try and get the room as dark as you can, because you can see the reflexes better then. Place your hand on the patient's nose, so you're sort of blocking the light as much as you can. You're shining the light into one eye and looking to see if the pupil constricts. And then you're shining it into the same eye and looking to see if the other pupil constricts, which is your consensual response. And then you're swapping, so keep your hand in place and then do the same with the other eye. Cranial nerve 2 is your afferent, so sensing the light, and then cranial nerve 3 is your efferent, so causing the pupil constriction. You'll then do the swinging light reflex, which I'll describe on the next slide in conjunction with some pathology. And then the other thing that you would want to do for your reflexes is your accommodation, which is actually sort of cranial nerve 3, but it's easier to do all of your reflexes together. So I asked the patient to look at a point of the curtain behind me, and then I asked them to keep looking there, and I put my finger in front of their face. When I say now, look at my finger, and you're looking for the eyes to converge and the pupils to constrict. So your swinging light reflex, it's similar to your direct and your consensual, but you're looking for different things. So you're going to have your hand between their eyes again to try and block out some of the light. You're going to make the room as dark as you can. And you're going to swing the light between each eye for 1 second at a time. So 1 second, 1 second, 1 second. What should normally happen is you should shine the light in the eye. The direct reflex in that eye should cause pupillary constriction, and the consensual reflex in the other eye should cause pupillary constriction to the same degree. And then when you move the light to the other eye, there should be the same level of light detection. You're shining the same light in the eye, and the pupil should constrict the same amount, so there shouldn't be any change. If there's cranial nerve 2 damage, so partial lesion, the eyes will constrict less than you would expect them to when you shine the light directly into that eye. And that's because it's not sensing the light as well. So there'll be lesser constriction, which to you will look like slight dilation. So when you're doing a swinging light reflex, you're looking into the eye that you're shining the light in. And if there's pathology or a relative afferent pupillary defect, you will see what looks like slight dilation, but it's actually lesser constriction, and that is commonly associated with multiple sclerosis. So I've gone through some other pupillary common sort of pathologies. So a lot of these are named after people, but I think they're really commonly tested in MCQs, so they're quite worth knowing, and you could have a patient with one in an OSCE. So a Holmes AD pupil is as a result of ciliary ganglion damage. You'll have one tonically dilated pupil and one normal pupil. The pupils will be poorly responsive to light, but they have good accommodation. An Argyll-Robertson pupil is really associated with neurosyphilis, and it's quite sort of pathognomonic. Both pupils will be small, constricted. There'll be no response to light, but the accommodation will be good. Horner's syndrome, highlight the mnemonic PAM, so ptosis, drooping of the eyelid, anhidrosis, loss of sweating on half of the face, and meiosis, pupillary constriction. And this occurs due to damage to the sympathetic trunk, so you get unopposed parasympathetic innervation. The really sort of medical school exam answer is a Pancoast tumour, which is an apical lung tumour, which can compress on that trunk. But some other good differentials are MS, you might get sclerosis of those sort of nerves, and a carotid artery aneurysm or dissection, because where the carotid artery lies, you can get sort of a mass effect and compression of the sympathetic nerves. I thought I'd also put in some drug causes, and I think these are quite nice differentials. So atropine and amphetamines can cause a dilated pupil, and opiates and pilocarpine can cause a constricted pupil. And I think just for some integration of knowledge, that's why you use pilocarpine for acute angle closure glaucoma, because you're constricting the pupil to widen the angle of drainage for your aqueous humour or your aqueous fluid, to lower the pressure in the eye. So I think sometimes it's quite nice to bring across different bits of medicine to try and really consolidate your learning. Other causes of ptosis or drooping eyelid, it's a cranial nerve 3 palsy, because as we'll come on to speak about, cranial nerve 3 supplies the superior levator palpebrae muscles, which are responsible for your upper eyelid, and Horner's syndrome that we spoke about. And then if that is bilateral, some differentials for that are myasthenia gravis or myotonic dystrophy. So we've finished cranial nerve 2 now, once we've offered our ophthalmoscopy and our other tests that we've spoken about. And we'll move on to cranial nerves 3, 4, and 6. So these supply your muscles that help move your eyes. So there's a nice mnemonic SO4 LR6. So your cranial nerve 4, your trochlear nerve, supplies your superior oblique muscle. And cranial nerve 6, your abducens nerve, supplies your lateral rectus muscle. And then oculomotor nerve supplies everything else. So we'll go through quickly what muscles do what to the eye, because I think it's important to get your head around, especially as some of the names of the nerves don't feel obvious as to what they do. So your medial rectus moves your eye nasally or inwards, and that's supplied by cranial nerve 3. Your superior oblique, which is your SO4, so supplied by your trochlear nerve, moves your eye downwards when your eye is turned in. So it doesn't move your eye up. When your eye is turned in, it moves your eye down. Your inferior oblique, supplied by cranial nerve 3, does the opposite. So when your eye is turned in or nasally, your inferior oblique muscle moves your eye upwards. Your lateral rectus does what it says on the tin, so it moves your eye laterally or sort of abducting, and that's supplied by your abducens nerve. And then your superior rectus and your inferior rectus are both supplied by your oculomotor nerve, and it moves the eye up and down respectively when your eye is already turned out. So how do we test these cranial nerves? So first by looking. We spoke about it at the beginning, but does the patient have any obvious sort of difficulty looking around the room or following you when you're entering? H test is your smooth pursuit. So that's essentially you're asking the patient to keep their head still and sort of directly in line with you. Using both hands, so start in the middle, you're going to draw a really big H, sort of as big as you can to assess their extremes of vision. I like to start with my finger vertically when I'm moving out, and then I like to turn it to the side to go up and down, come back to the midline, swap hands so I can go out to my extreme of vision again, turn up and down. The really important thing to do before you start doing a H test is to tell the patient to interrupt you if they have any double vision or pain. I've seen it quite commonly where you do your whole H, you ask the patient if they had any double vision or pain, they say yes, you ask whereabouts in the H that was, they can't tell you, and then you end up repeating it all again. So ask them to interrupt you before. When if they have that double vision, we'll come to talk about why, but ask them if the fingers look like they're next to each other or on top of each other. And that's why when I'm sort of at the side, I commonly turn my finger to the side, because then the patient can see if they're above. If they look a bit confused, you can always then turn your finger back, because it might be that they're sort of side to side and they're overlapping when your finger's one way or the other. The other thing to do with your H test is when you're at the very lateral portion of their vision, is to hold your finger there, as that's where you'll commonly see nystagmus, which is flicking of the eye. And sort of the pathological nystagmus is more than 5 beats. And I'll explain how to do it on the other slide, but saccades and strabismus you should also assess. And then the 2 reflexes that you should offer at this point are your jaw jerk and your corneal. But again, I'll speak through how to do that in case you're either expected to do it or an examiner might ask you how to do that. So common causes of nystagmus are stroke, cerebellar disease. So if you know your Danish or your Danish PR mnemonic, then it's the N in that, and any inner ear disease, for example, Meniere's. And then your pain is really classic of optic neuritis, which we spoke about earlier, associated with MS and commonly occurs in conjunction with red desaturation, so not seeing red as you normally would. So apologies, this is quite a busy slide, but I thought I'd go through the different cranial nerve palsies. And I really think for the first portion of the cranial nerve exam, this is probably one of the most likely things that could come up. So I think if we start on cranial nerve 3, so we spoke before about how cranial nerve 3 supplies all of the muscles apart from your superior oblique and your lateral rectus. And if you have a palsy of that, it means you get unopposed sort of movements of the muscles that aren't supplied by cranial nerve 3. So you'll get a down and out eye position. And if you think about why, it's because your lateral rectus is pulling your eye outwards, abducting, and then part of your function of cranial nerve 4 supplying the superior oblique is to pull the eye down and inwards. So cranial nerve 4 superior oblique moves your eye downwards when it's turned in, so you get a combination of the down and then the moving the eye out. You'll get ptosis because, as we spoke about, cranial nerve 3 supplies the muscles that are responsible for the upper eyelid movement, and you can get double vision. In a surgical cause, so in the causes column on the far right, you can see they're the ones with the C's. You get compression of the parasympathetic fibers. So you get, because they lie on the outside of the nerve, so you get unopposed sympathetic tone, which causes pupil dilation, and an unreactive pupil. So your surgical causes: posterior communicating artery aneurysm, a cavernous sinus lesion, sort of something like a thrombosis or a mass, and another type of cancer. And then your medical causes are your things that cause sort of your neuropathies in other parts of your body. So think about things like diabetes, MS, and migraines. If you have a cranial nerve 4 palsy, it means that your superior oblique's not working. Your superior oblique, as we said, moves your eye down and inwards. So when the other muscles are working apart from that one, then your eye will be up and out, the opposite. You get diplopia, so double vision, worse on downward gaze, and that's because your superior oblique is responsible for moving your eye down. So when the patient is trying to look down, they've got uncoordinated eye movements. Things that can cause this are congenital problems, a primary tumour like a schwannoma, so of the nerve, and infections like meningitis. And then the last palsy that we'll speak about is a cranial nerve 6 palsy. So that's a palsy of your lateral rectus muscle, so moving the eye outwards or temporally. You can't abduct the eye, or they can't do it very well. So you get double vision worse when they're trying to do that. And cranial nerve 6 has the longest course through the brain. So things that raise your intracranial pressure really commonly cause a cranial nerve 6 palsy. So that can be a thing like a stroke, a bleed, a tumour, or any sort of trauma. So the reason I said to try to distinguish between whether they can see your fingers above each other or next to each other is because different pathologies cause different types of double vision. Unhelpfully, thyroid eye disease causes both, but they'll also be associated with other signs like exophthalmos, so protrusion of the eye, lid lag. So when you're asking the patient to look down, their sort of eyelids will come down slower, and also retraction. Multiple sclerosis, we'll speak about that pathology because I think it's worth going into more detail of, but your vertical diplopia is caused by palsies that are responsible for sort of eye movements up and down. So cranial nerve 3 supplies your superior rectus, and cranial nerve 4 so goes down, so your superior oblique. So they're the ones that typically cause a vertical diplopia, or they're seeing the fingers on top of each other. This is a quick slide on internuclear ophthalmoplegia, which is a lateral conjugate gaze palsy that's associated with multiple sclerosis. You get a sclerotic lesion in your median longitudinal fasciculus, or MLF, which is essentially a really highly myelinated part of your nerve, which is why it's sort of predominantly affected in MS. The patient, when you ask them to look one way, will look one way completely normally. So here, this would be if the patient was facing you, the patient would be able to look right normally. If you ask the patient to look left, they'll be able to fully abduct their left eye like normal. So their lateral rectus will be working in that eye. But they won't be able to adduct, so move their right eye nasally in conjunction with that left eye movement. And we normally do that so we can shift our visual field to focus on something more laterally. And that's because that nerve is responsible for communicating between the eyes. You'll also get nystagmus of the eye that's working normally. And that's just as it's trying to pull the other eye to look the other way or flick back and forth to try and stimulate that movement. So I think sometimes this confuses people a little bit because it doesn't really fit into a specific palsy. But if you think about an isolated problem with adduction of the eye, then it's likely to be this, because your sort of medial rectus is supplied by cranial nerve 3, and that also supplies a lot of other nerves. So if you had a problem with your cranial nerve 3, it would be affecting a lot of other eye movements, not just this in isolation. So I think if you're feeling a bit confused about which nerve is responsible, just bear this in mind in the back of your head, because it's really commonly assessed, and it's quite a nice bit of how pathology translates into a clinical sign. Testing saccades, so one hand into a fist, one hand into a finger, and you're essentially assessing how a patient can move their eyes rapidly between the two. So can you look between my finger and my fist as quickly as you can? If it's slow, it might be because of a cerebellar problem, or amyotrophic lateral sclerosis, so the most common form of motor neuron disease. If you feel that they're looking past your finger or past your fist, that again might be because of a cerebellar problem. But if you feel that they're undershooting or they're not quite hitting that with their gaze, a common cause of that is myasthenia gravis. And then strabismus is essentially misalignment of the eyes. So there's 2 tests, and I've never done these in an OSCE, and I don't think you would be expected to do them, but it's quite a nice one to offer. So strabismus is squint or ocular misalignment. So you're essentially, for your Hirschberg test, you're asking them to look at a 50 sort of centimetre target, and then you're shining a light in the centre of their eyes, which is at their nose, and then you're looking for symmetrical constriction of the pupils. And if it's asymmetrical, that means there's ocular misalignment. And then your cover test, you're just covering one eye, and if you get movement of the other eye, again, it means there's misalignment. And then we are running out of time, so we'll move sort of swiftly on to cranial nerve 5, which is your trigeminal nerve. There are 3 divisions of your 5th cranial nerve. So the first 2, your ophthalmic and your maxillary divisions, are purely sensory, and then your third division is your mandibular nerve, which is sensory and motor. So I always think about sensory first, I'll assess, and then I'll assess my sort of motor function after that. So you can see from the diagram, your first division sort of provides sensation to your scalp, your forehead, your nose, eyelids, eyes, and that includes your conjunctiva and your cornea. So when I'm testing that, I'll test above the eyebrows. Your cranial nerve 2 tests your cheek, nostril, sort of upper lip, upper teeth, gums. So when I test that, I'll test it sort of over the zygoma here. And then your mandibular division provides sensation to the lower part of your face, so sort of mouth, lower teeth, lower gums, jaw, chin. So I'll test it on either side of the midline here. The trick with sensation is to test 2 components, so pinprick and fine touch. So pinprick with the neurotip, and fine touch with cotton wool. And to not say, can you feel this? Can you feel this? Can you feel this? Can you feel this? Ask the patient to say yes when you touch each side of their face, so they're sort of saying it themselves rather than reactively giving you the answer that you want. And also, after I've tested each division, I'll ask them if it feels the same on both sides. So I'll feel one side, I'll say yes when you can feel it, yes, Yes. Did that feel the same on both sides? Yes. And then move to the second division. The motor component, you're testing your muscles of mastication. So you're feeling the temporalis muscle, which is in your temporal, so sort of lateral to your eyes, and then your masseter muscle, which is slightly lower. And put your hands in the correct place, ask the patient to clench their teeth, and you should feel muscle movement. It should feel symmetrical on both sides. And you're going to test the power of the pterygoid muscle, so ask them to open their mouth. Ask them to try and keep it open when you're closing it and provide some resistance. If there's a cranial nerve V3 lesion, so the third part of your trigeminal nerve, there'll be weakness and the jaw will deviate to the side of the weakness. The reflexes you should offer are your jaw jerk reflex, which afferent and efferent are your mandibular part of your cranial nerve 5. So ask the patient to loosely open their jaw and relax as much as they can. You should put your index finger on their chin and then use a tendon hammer. Normal is for the jaw to slightly close. And if there's an upper motor neuron lesion, there'll be brisk, sort of complete closure of the jaw. And then your corneal reflex, essentially will ask the patient to bring the lower part of their eyelid down and look upwards, and then using a bit of cotton wool, you'll touch the cornea. And normal is the sort of direct and consensual blinking. And that's because the stimulus, the cotton wool is picked up by the cranial nerve 5 part 1, and then your eyes will close because of your cranial nerve 7, which innervates your muscles of facial movement. If there's a problem with your trigeminal nerve, the patient won't feel the cotton wool because it's not picked up, and there won't be a blink response. But if there's a problem with your cranial nerve 7, they'll be able to feel it, but they won't be able to blink because the innervation of those muscles isn't there. I've never done these in an OSCE, but they're 2 to offer for your examiner to know that that is how you would assess those reflexes. I've heard a lot of examiners say they get really frustrated when medical students do great exams and then forget to thank the patient at the end. So always try to remember to thank the patient. They've given their time as a role player, and less relevant in this exam, but I always offer to help them redress. Then wash your hands. You just examined a patient. That's what you do in real life, so that's what you should do in your OSCE. You then summarising, which I think is often the most dreaded part of a OSCE station for a lot of people. So the way I used to do it was I'd run through the whole examination in my head of what I've done and sort of list the positive and negative findings. I think the problem with that is that you can lose the positive findings in amongst the mess of all the things that were normal, and it doesn't really lend itself well to synthesizing your findings into a working diagnosis. So the way you should do it, I performed a cranial nerve examination on this person. That sentence is a really nice, easy thing to say that you can say without really thinking, and start to think about the next things you're going to say. They were comfortable at rest. They likely will be in an OSCE. And you can say on general inspection, the patient was, if there was any positive findings. The key positive findings on examination were, I think is quite nice to think about in a cranial nerve examination because they'll often be associated with one nerve. So you can think about what did I test for that nerve and what was negative. And then you can say these findings are consistent with a diagnosis of, or in this exam, I think these findings are consistent with a problem of this cranial nerve, differential diagnosis of which could be these. And then we spoke at the beginning about most likely rule in, rule out. I've listed some further examinations there for you, so you can always offer a full history. Think about the other types of examinations you want to do, and then try to structure your thoughts into bedside, bloods, imaging, and special tests, and think about those pathologies that you've listed as differentials and what investigations you would need to do to rule them in and out. And then this table essentially summarises all the starred parts of the slides that I spoke about before. So what additional tests can I do to further assess the cranial nerves that I've already examined? So to conclude, we've gone through cranial nerves 1 to 6, and hopefully for each of them you feel a little bit more confident now on what that cranial nerve does, how you can examine it with some of my top tips and some high yield pathology. We'll be going through the other cranial nerves, so 7 onwards, next week at 6:30. But if there are any questions in the chat, we can go through them. Otherwise, enjoy your evening. I've also got this feedback form if people are happy to give feedback, and hopefully we can apply that to the later sessions that I'm doing. Yeah, I'll leave it there.